board certified. He's a board certified child psychiatrist and pediatrician at Thunder Mist Health Centers, Hasbro Children's Hospital, and Emma Pendleton Bradley Hospital in Rhode Island. He's a clinical assistant professor in the Department of Psychiatry and Human Behavior at the Warren Alpert Medical School of Brown University. Graduated from Harvard Medical School and obtained postgraduate training through the Triple Board program at Brown University. The Triple Board is a combined program in pediatrics, general psychiatry, and child and adolescent psychiatry. He has additional degrees from Harvard University in public health, concentrating on maternal and child health, and education focused on adolescent development and psychology. He is involved with the American Academy of Pediatrics, frequently reviewing policy and publications related to LGBTQ health. In fact, he was recently the lead author of the AAP's policy statement, ensuring comprehensive care and support for transgender and gender diverse children and adolescents. And with that, I am passing it over to Dr. Rafferty.
Can you hear me now?
Yeah, we can.
Okay. I'm like talking to myself and I'm like, can you all hear me? And there was no response. Well, thank you for the introduction. I'm really, really happy to sort of be sharing, this grand rounds with you, to be talking about this topic. I will apologize in advance. So part of my job, I work at a high school and I'm there today, and it's usually a nice quiet office, but as we approach dismissal, if you hear a bell ringing behind me, that's what it is the kids going home. But anyway, today I'm going to be talking about caring for gender diverse youth. And just in terms of disclosures, I have no financial relationships to sort of disclose related to any of this. We will, as we go forward, talk a little bit about off-label use of medications, which I'm sure in child psychiatry, many of you are probably well familiar with. That we use a lot of medications off-label, but anything that I talk about today, any hormone use, any puberty blocker use, things like that, are all off-label use when we talk about gender care. I also, just in terms of affiliations, just throw out there, I am, as was mentioned, I'm on the American Academy of Pediatrics section on LGBTQ health and wellness. We're on the executive committee, and actually now I'm the chair. And I work in 3 sort of healthcare systems in Rhode Island, and also at the Warren Alpert School of Medicine. The other thing I would just sort of throw out there too is, I'm doing this lecture on gender diversity. I will say I am not transgender. I don't identify as transgender. The stories that I talk about today and the experiences and things like that really come from the understanding that I've built over time working with my patients. And so I don't want to have them sort of come across as like my own experience, but at the same time, I'm really humbled that so many patients have been so open and honest about their experiences. I really have learned from them, and this is a product of sort of what I've learned in my own clinical practice. Our objectives today, we're going to describe gender identity, gender and identity development, and sort of how our understanding has evolved over time. Talk a little bit about the gender affirmative care model. I'm going to go through some of the core tenets sort of individually, and then sort of come back to the model in of itself. And this is probably when I talk through the AAP, I talk to a lot of reporters and a lot of media, a lot of politicians about this. And the number one question I get is, what is gender affirmative care? I think this is a really hot question, and hopefully something that today you guys will all walk away with a better understanding of, so that you'll be able to answer that question more confidently and so forth at the end of this talk. We're going to talk a little bit about terms and concepts that I think are really key. Granted, there's a lot of terms out there, but some of the ones that I think is just that are really important to sort of be aware of. And then finally, I don't know why it goes 1, 2, 3, 2, but number 4, I'm going to talk a little bit about some of the health disparities and where they sort of come from, especially when related to mental health. So the way I've sort of set this up is I'm going through some of the questions that parents have often asked of me. And so that way, in some ways, some of these answers you might be able to use in your own practice as a way to sort of talk to your own families and patients' families, things like that, about when you get these questions. So why are there so many terms and labels? Well, the reason I think that both this is an important topic, especially right now, and a sensitive topic and controversial topic, and the fact that there are so many labels evolving, all start with this sort of notion. Now, this picture came from an old catalog. I think it was actually a Sears catalog, and people now are like, well, what is that? But it's it is a nursery, obviously, and this child may not even be born yet, but I think all of you probably can take a guess as to the gender of this child. Um, this room is full of expectations, it's full of, sort of assumptions. Um, that this child may grow up to like sports, that they're going to like sort of the more masculine colors of sort of blues and oranges compared to like pinks and purples. There's a lot here. And there's a lot here, like I said, this child may not even be born, and yet we're already projecting so much on who this child's going to be, what their life track is going to be. And this isn't unusual, right? Gender reveal parties, and everybody asks first thing when somebody's pregnant, do you know the sex of the baby? Do this is really big, and for parents, it becomes a very sort of fixed notion from a very early age on who this child is going to develop into. Part of this is because of how we understand child development. Some of this is how we understand child development, which really comes from Lawrence Kohlberg. Probably many of you are familiar with Lawrence Kohlberg because of the work that he did on, moral development. But he actually, little less known is his work on gender development, even though this theory, I think, really centers on a lot of our early understanding and so forth. So essentially, it suggests that kids go through 3 stages, starting with gender identity development in preschool, your ability to start using labels to describe who you are from a gender perspective, understanding that maybe there's different bathrooms for boys versus girls and things like that, or understanding young kids really focus on differences. So understanding that, I'm a boy and this is what doesn't make me a girl, whether it be their body parts, the way they dress, the way they do their hair. Young kids just are very in tune with that. However, as you all know, in terms of child development, there's a lot of fantasy and flexibility with young kids in terms of how they see themselves and how they engage in play. And so often this first stage lacks a lot of permanence. It's very flexible. So for example, in class at preschool, you might see yourself as a boy and you understand that the boys' bathroom is the bathroom that you use. But meanwhile, while you play house with your friends, you might take on the role of the mother. And in that, it's actually a very realistic studies tell us a very realistic role. When young kids sort of take that on, they really become fully immersed in that role. And there's a sense that they actually, that this is who they identify with while they're engaged in that sort of play. So there's a lot of flexibility around them. Kohlberg kind of said that by the time kids start to reach kindergarten, it becomes a little bit more stable. The kids start to understand that over time, even though that you may pretend to be one gender or another, that your ultimate sort of identity underneath it is relatively more fixed and stable. But there's also this sort of belief that who you are can be modified fairly easily by how you present yourself. So by the way that you're sort of, thinking again, as these kids is very concrete developmentally, thinking that long hair means that you're a girl, or that if you wear a dress or a skirt, that means you're a girl. Whereas maybe if you like certain certain action figures in video games, that might be more implied around sort of a masculine identity. So there's this concreteness that sort of is starting to sort of emerge around this time, but also this sense of more stability. And then what he said was really around the age of like 6 and up, around school age, kids develop this sense of gender consistency, that really you are who you are, that you have less control over that. And what he sort of theorized, which I'm not implying is right, but really that throughout school age, if you don't really figure this out, it sort of sets the stage for difficulty, psychosocial sort of difficulty throughout much of the rest of your life, if you don't feel that you have a secure sense of gender identity. So obviously that last stage, is a little bit more questionable with our current understanding, but I think it's important that we just recognize that this model is really ingrained in a lot of even current educational teaching, a lot of social work and counseling and things like that, and why we sort of approach, some of the sort of understanding of identity the way that we do, the assumption that kids develop a gender identity at such a young age, and especially the permanence, really comes from this theory. The problem with this theory is that from a young age, it essentially is suggesting that there are 2 boxes that people sort of fall in, girl or boy, and then it really that anything outside of this is setting you up, really for difficulty, or it's sort of pathologizing anything outside of this later on. And I think what we're seeing today with a lot of young people presenting to our clinics is that this model doesn't work for how they see themselves, that they're really starting to challenge this and saying, wait a minute, this isn't what we've assumed for so long, these assumptions about gender development, is not necessarily true. And here I am as an exception. So around like the 1990s, this sort of the genderbread person came onto the scene. And this was sort of the idea with that first sort of, if you guys can see my mouse, this first sort of spectrum, is the idea that on one side you have woman, on one side you have man, and that we all kind of fall somewhere on this spectrum in between these two extremes. This came out of the research from Dr. Kinsley on sexual orientation. Essentially, you could fill out a survey, and it suggested, as it shows down here at the bottom, that sexual orientation is on a spectrum between heterosexuality and homosexuality, and we are all various, forms of bisexuality. And the assumption was, well, if this theory seems to work well for sexual orientation, maybe it also works for gender. And so for a while, this started to capture people who didn't fit in these sort of two boxes in a way that seemed affirming, but very quickly, it also presented some limitations in how static and rigid being on a spectrum really was. So then in the early 2000s, the genderbread person was replaced with the gender unicorn, where people started to say, why is there a zero-sum sort of spectrum? Maybe in terms of gender identity, there are different, there's a different spectrum of femininity that people have, a different spectrum of masculinity. We have a spectrum of other things that maybe inform our identity that don't necessarily, get a label. And that gender identity is separate from gender expression. And there are different, there's the same spectrums in sort of each realm. And they even went so far to suggest that in terms of our sexual orientation, that physical attraction is distinct from emotional attraction. And I will say that for young people, this provided a sense of complexity that seemed very reassuring. And even today, I have young people that continue to come in with this, like a coloring sheet of this and showing where they are on the coloring sheet. But as many of you can imagine, for parents, this was like, oh my God, what is going on here? Why do there have to be so many spectrums? Why do there have to be so many ways to understand yourself? This is like, it became mind-boggling and overwhelming for parents to sort of have so many things going on that they need to think about in terms of how their children sort of identify and to think about the developmental, trajectory of their kids. So more recently, probably in the last 10 years, the gender book came on the scene. The Gender Book is a free resource online. I highly recommend it. It's www.thegenderbook.com. There, you can actually, I forget, for like basically the cost of the book, you can get the actual physical book sent to you. But most of the diagrams are online, and I use this with a lot of my patients. It's a really wonderful resource. I'll pull it up on the computer, and we'll talk about, some of the analogies that they present. But when they talk about sort of gender identity and sort of like where things, how to sort of conceptualize this, they look at it as a planet. That essentially there are these two large continents, Ladylandia and Manlandia. And we're all born on one of these continents in terms of what sex we're assigned at birth. Each of these continents are incredibly diverse. You got, for example, in Ladylandia, you got Tomboy Town, you have the feminine foothills, you got the girly grasslands. There's all these different subcultures, there's all these different places where people fit within this continent of Ladylandia. Despite that, down here at the bottom, you can see this little cruise boat floating around. The gender fluid cruise boat comes into port every so often. And you might hop on board and it might travel you from Ladylandia across to Manlandia, where you might experience a culture that's very different from your own. As people know who might have studied abroad, you can immerse yourself in another culture and learn a lot about yourself through understanding beliefs and customs and practices that are very different to maybe what your understanding of the world was, or express different sort of conceptualizations and assumptions, things that really challenge those assumptions. And so I think that's important to a lot of people's development. Now, some people will say, in terms of Ladylandia, despite how diverse it is, the real culture that really fits who I am is really in Manlandia. And they may stay there. And that might be what we consider sort of traditionally as transgender, that you've gone from one continent to another. Other people might hop back on board the gender fluid cruise boat. They might travel back to Ladylandia, or they might travel to some distant seas. You can see here, there's a third gender island saying, I see that there's Ladylandia and Manlandia, but I really feel that I belong somewhere else. There's a gender diverse island, this one here that sort of encapsulates through the blending of color, this idea of the spectrum, that I feel like I'm somewhere in between on the spectrum between male and female. You see the gender neutral, down here at the bottom, like the Antarctica, saying, okay, I see Ladylandia and Manlandia, but I really feel I'm 50% in the middle. I have a little bit of both, I have about the same of both, or sometimes it might go back and forth in terms of which side of myself I sort of express. Some people might just pitch a tent and live right on their gender fluid cruise boat. And depending on what sort of setting they're in or situation, they might feel more masculine or more feminine. And that's okay too. There's also out here, out in space, if you guys can see that, there's a little satellite. This is the agender satellite. So these people are looking down on this planet, acknowledging that this is how, for most people, they're experiencing the world. But for them, it feels like a totally different planet to their experience of the world. That this term or concept of gender is out there, but it doesn't really define my identity. So I really like this sort of model for a couple reasons. The first one being it introduces a dynamic nature to the sense of gender identity. That based on where we are developmentally or where we are in terms of our context or our culture or situation, there may be variations in how we see ourselves because we're introduced with new ideas and concepts and assumptions, like I said, that might shift a little bit how you sort of see your identity. And so things can change over time based on these new experiences. The second thing that I really like about this analogy is that gender is not something that's inherent to the person. It's something that really is defined through relationships with others. It's a socially constructed term. It's through these sort of subcultures and interactions and discussions with others and shared aspects of identity that we begin to label and talk about who we are and understand who we are. And I think that's really important because we know we are all unique individuals. And the way that we see ourselves, whether it has to do with race or ethnicity or ability and also gender, is unique to each and every individual. So I think this really captures that it's an imperfect science of labeling. It's an imperfect science of defining sort of, what gender is. But, it really is constructed through culture. In the context of all of this complexity, there are some terms that I think it's really important to know. The first is sex, gender, and sexuality. So sex and gender are different. Sex is a label that usually you're assigned at birth. It's often male or female, although sometimes if there's some sort of differentiation of sexual development, ambiguous genitalia, or sometimes chromosomal abnormalities like Turner syndrome, you might not exactly fit into a biological definition of male or female, and that experience is known as sort of intersexuality. That it's basically the label of sort of the condition is DSD, disorders of sexual differentiation, but the experience is called intersexuality, where really you're sort of it's a little bit confusing at birth. It's a little distinct from people who are transgender because often this is something that's determined early on in life before you have any say into what your actual identity is. And throughout history, sometimes people have tried to intervene early on in life before actual patients have had the ability to sort of provide input into what would be most affirming to who they are. Gender is different. Gender is that feeling usually on the inside of who you are, and it doesn't necessarily match always the label that you're sort of assigned at birth. So I think that's important. That distinction is really important. Gender can be further divided into three sort of areas, which is the next bullet point. Gender identity, as I said, is usually what you feel on the inside, your sense of self and who you are. Gender expression is how you present yourself to the world. And gender perception is how the world actually perceives you. And then the last term there, going back to the bullet point, sexuality, is a whole sort of different sort of concept, right? That describes who you're attracted to, who you have intimate relationships with, who you have romantic relationships with, and also what you're doing intimately with other people. So sexuality is a very broad term, includes sexual orientation, includes sexual behaviors, emotional versus physical attractions. There's a lot that goes into sexuality. I don't want to minimize that. Today, we're sort of largely focusing on gender, but it's just to sort of, draw out those things as separate from the discussion we're having focusing on gender, which is also separate from assigned sex at birth. The third bullet point, gender diversity, is a large umbrella. It's even more broader than the term transgender that really sort of encapsulates anybody who sort of feels that their sense of self is diverse from what other people may feel. It's the same. I often talk about it in the same way that I talk about racial diversity or ethnic diversity or ability, or there's so many ways humans are different from each other. this term used to be gender nonconforming. But I think we can all sort of acknowledge that that comes from a place of cisgender privilege where, really the conforming or the normal is the cisgender or the non-transgender experience of people whose assigned sex at birth is the same as their sort of gender identity. And it's pathologizing in some sense to people who don't necessarily conform to that sort of, assumed normal. So we've tried to change that to a more sort of strengths-based and positive term, which is where gender diversity comes from. And again, with the drawing out of the idea, this is just one more way that people are diverse from each other, which is a totally normal part of the human experience. The next bullet point, gender dysphoria. So again, previously that was called gender identity disorder in the DSM-4 and even previously in the ICD-9 and things like that. Gender identity disorder, though, really was largely defined based on someone's identity. If you had an identity that was gender non-conforming, again, a very pathologizing term, then you automatically had a diagnosis of gender identity disorder. Gender dysphoria, although not, clearly there are limitations with this diagnosis. I don't want to sort of imply that this is perfect, but it is definitely a significant step that happened in the right direction with that was introduced in DSM-5. Gender dysphoria is very clearly about the experience of the person who is gender diverse, that experience, for whatever reason, creates so much distress that it is impacting your functioning. It's might be leading to contributing to outcomes such as depression or anxiety, negative sort of mental health outcomes. And actually, the way that I usually talk about this when I see a patient, we talk about is gender, is I go back to those three different, sort of realms of gender, the identity, expression, and perception. And I say that really gender dysphoria tends to emerge when those three things are incongruent. For example, you might have been assigned male at birth. You might feel more feminine in terms of how you actually see yourself on the inside, but maybe you don't feel safe or comfortable expressing yourself that way to the world. So you might try to overcompensate through the way that you sit, you walk, the activities that you sort of engage in. So that way that you're presenting yourself to the world is your expression. But as much as you may try to hide it, people may still assume or perceive you as feminine. And that might lead to bullying, that might lead to people talking behind your back. And so you can see how when these things are incongruent, it can actually cause a lot of internal distress within that person. The ideal situation is that somebody's who they are on the inside, they can openly express to the world and that they can be appreciated and accepted for who they are. But when it's incongruent, that distress, that's what with patients, I really say that's the gender dysphoria. And it's not to say that everybody who is transgender or gender diverse experiences gender dysphoria, but really that many do. And it's something that when they do, they come to us, to really sort of help them through, whether that be through sort of physical affirmation or more sort of mental health interventions or things like that. So hopefully that's clear, the distinction between gender dysphoria and gender identity. Not everybody who's trans has to have gender dysphoria. The next term is gender affirmation, which used to be referred to as gender transition. And a lot of people still who are transgender and gender diverse use the term still transition. But I think there's one key difference in the use of these two terms that sometimes I even educate patients about. Transition implies that as a person, you've started somewhere and that you have changed. The key difference with affirmation is it reflects the fact that the person on the inside, the gender identity, has not necessarily changed. You might have gone through a process of discovering who you are, but that who you are is theoretically always who you are. You're going through a process of better sort of articulating it and discovering it, but your sense of self is who you are. The change is by the world around you in terms of being able to understand, accept, and affirm that sense of who you are. And so with affirmation, the sort of locus of responsibility is really on society, on the people that surround you, whereas on gender transition assumes it's on the person themselves. And I think that's a very important distinction. Especially in terms of, again, wanting to use more strengths-based language and some of the, wanting to use more strengths-based language and assuming that who you are is who you are and that is worthy and deserving of support, love, and affirmation. And as I talk about these things, obviously the last bullet point that I want to really pull up there is acceptance. Many people inaccurately see acceptance as black and white. Either that you are 100% accepting and fully sort of woke or whatever, sort of term you want to use, or you're completely rejecting. And I will tell you that is a trap that is very dangerous, I think, in the field of child psychiatry. The reality is that everybody goes through their own process of building understanding and their own process of really sort of, supporting and accepting, who they are, who their children are, and things like that. And through that process, every additional sort of piece of acceptance or understanding that people are able to develop builds resiliency. And so it's not a zero-sum game. It's not, one or the other, black and white. There are a lot of shades of gray when it comes to acceptance. It is important that as a mental health provider, that we really recognize and we celebrate when acceptance is moving in a forward direction and not necessarily shut people out as being rejected. Because everybody, like I say, everybody has their own process, and we want to keep building on their education and their sense of of gender identity and just how complex that is. Another question that people ask me a lot is, do transgender people consider themselves to be gay or bisexual? Well, sometimes, usually, and as we just talked about, gender identity is not synonymous with sexual orientation, which often refers to the identity in which people are attracted both romantically and sexually. A person who's transgender still sees themselves as gay, straight, bisexual, or something else. So I think we all, we've talked about that. I think we can all sort of understand that first part of it. But it is complicated. And I think sometimes the complexity around this is sometimes minimized. And I personally think that's unfortunate, because I think the complexity is really rich and important to explore. These concepts of gender and sexual orientation are actually quite interrelated, because sexual orientation is based on the identity of the gender identity, usually of your partner. So if your partner comes out as trans, you may go from using a label of gay to now using a label of straight or something else. That makes this very complicated, because then that shifts, sort of a sense of whether you're in a minority group. It might shift some of the stigma or some of the discrimination that you might feel. There's a lot of complexity around your sort of experience based on your sexual orientation, which is also based on the labels of your gender labels of who you are and who your partner is. So I think that I would say looking at that interrelatedness is important and really shouldn't be minimized, especially when you're talking to patients and families. There's a lot that can come from it. How should you refer to a person who is gender diverse? So this is really the gender person 2.0 revised. After talking about the planet and everything else, it's simple. Just ask your patients, just ask people, how do they identify themselves? And if they provide you with a label, even if it's a label that you're familiar with, it's always important to explore that. It's incredibly empowering to your patients to be able to engage and educate you as their provider, but also it's incredibly informative to you as the provider to hear the patient's perspective and understand the complexity that they're sort of trying to pull together in terms of the label that they use. And I will tell you, you meet two people who are genderqueer or pansexual, like you meet two people, you've met two people. They are not necessarily using that label in the same way. And the distinctions in terms of how they're using that label, I think is really important in terms of how you can, understanding how you can best support each of them. Can young children really know if they're transgender? So there's been these are a little older now, but I think these studies are still relevant. Back in 2012, this study came out, and it suggested that 2 to 10% of children under the age of 12 display regular gender diverse behaviors, and very few express interest in changing their gender. In addition, in the study of 9,000 kids, or about that, 83% of those reporting gender diverse play in childhood later identified as heterosexual cisgender adults. This builds on sort of traditional psychological sort of, research that's kind of understood that preschool children tend to use more gender confirming toys less and gender diverse toys more. So that'd be like a boy playing with Barbie or a girl maybe playing with trucks when they believe that they're alone, such as on one side of a one-way mirror. And that the frequency and intensity of fantasy play involving cross-gender roles appears to be the same among preschool boys and girls. And again, sometimes social stigma and pressures play into that, but when they believe that they're alone, you see a lot more gender diverse sort of interaction and play sort of emerging. So this tells me that in most of these young kids, there's a sense that, there's an importance and a sense that, of gender is something that's very fluid, as we sort of talked about. And the importance really is that exploring your gender through play helps you understand the world around you. We know that through other aspects of play, right? That this is how kids explore and how kids understand. So a young person who's assigned male at birth playing the mother when they play house might be their way of exploring, okay, what are the social stereotypes or expectations that a female, person or a mother or whatnot has on them in the context of a family dynamic. And that's a way a young child would do that, right? Through play. And so this is a normal process of identity exploration and development. And I really don't feel that it should be stifled, as much as I really don't feel that we should be trying to predict, based on how a young child presents, who they're going to be in 5, 10, 15 years down the road. The reality, and I go back to the statistic here about the 83%, when parents come in and say, hey, my 5-year-old or 6-year-old is engaging in gender diverse play, should I be worried? Do you think they're gay? Do you think they're transgender? I tell the parents, if I tried to guess, 83% of the time, I'd probably be wrong. And those statistics are not enough that I want to lean on. And so we'll talk a little bit about how to respond to that question. But the bottom line is that exploration of gender diverse roles is normal in young children as part of their social and emotional development. Now, in terms of how well a child knows who they are, what the research suggests is that children who assert a gender diverse identity, even at a young age, know their identity probably as clearly and consistently as their developmentally matched peers and benefit from the same levels of love, support, and social acceptance. So what this means is it's unreasonable to expect that a 6, 7, 8-year-old is going to know their sort of gender identity on the same level as somebody who is 18, 19, 20 or older, right? And that often in the political debate and things like that, these questions are, well, how does a young kid really know? Well, they know as well as other young children. And we don't ask kids who are basically cisgender, we don't ask them that, how do they know that they're not transgender? We accept that. And I think the same level of acceptance should be granted to people who are gender diverse. Now, there is this sort of, you may have heard of this, but there is this sort of strategy out there that I want to warn you all about called watch and wait. And this is the idea, and it used to be actually quite commonly accepted. Nowadays, we understand that it can be very harmful, but it used to be the case that for children, gender diverse assertions were held as possibly true and not acknowledged until an age or until enough distress had developed that the child was believed to know for sure whether they were transgender. And I think you can all understand, like our commitment as doctors, right, is to do no harm. So trying to sort of like, if somebody comes in and says, hey, I think I'm transgender, and we're like, okay, let's stick a pin in that. And I'm not going to acknowledge that you want to express, that you're bringing up this question until you become so distressed or until you become arbitrarily old enough that I feel that we can enter into this question. That is essentially you're causing harm. You're not serving the child because you're not increasing, because you're not increasing the support, the understanding, the exploration, the safety that child is really coming to you asking for. And ultimately, you're increasing just the discomfort that child has that they're trying to express to you. End of the day, any attempt at predicting, changing, or ignoring who a child may become have shown to be unsuccessful and even harmful. We know that more clearly with conversion therapy, which is psychotherapy aimed at trying to change someone's gender identity. But I think the importance here with watch and wait is, while this might seem like, oh, this makes sense in a young child, it actually, the ignoring a young child's sort of distress or curiosity or exploration can be equally harmful. So how do you assess, as a child psychiatrist, how do you assess a child's gender? Well, the most important thing in all of this is you have to be thinking developmentally. You have to be thinking about where that child is. And then in the context of thinking about the various developmental stages, so a young kid who may be more concrete and may have more sort of fantasy integrated into their understanding, or an adolescent who may be more abstract, we want to ask them, how do they describe their gender? How do they feel about their body and their body parts, as sort of a sense of, you can do that in the context of talking about self-esteem. You can do that in the sense of talking about, their sense of well-being, and things like that. But also you can get at their gender identity a bit too. And if anything is uncomfortable, clearly, if somebody wants to hurt themselves or their body parts, that's something that needs to be explored on the side of safety. As people sort of approach puberty, the question of how would it feel to go through puberty, growing up into a body that might more reflect your mom or your dad, or a male or a female, and exploring that with children. And one common technique that we use a lot in our clinic is sort of the self-portrait. I think a lot can be learned from kids as they sort of try to articulate through drawing, and again, also sometimes through play. But really, as they try to articulate this, allowing them the sort of flexibility to bring these ideas into their sort of artwork and then explore it with them, I think is just so rich and such a valuable way to get at some of this. We do know that, or some of the clues in terms of obtaining your history, that might start to emerge, that might give you a hint that that child is having some distress about their gender identity, includes bathroom behaviors, where they might be standing up or sitting down or preferring the men's room versus the women's room, where they might be sort of very uncomfortable in a public bathroom setting. That's something you might want to pick up and explore on a little bit. Swimsuit preference, underpant preference is something that sometimes will come up in the history, that is sometimes a flag that you might want to explore a little bit in the context of their sense of self. As we've talked about, toys and playmates is something that you might want to sort of like, if it comes up, any concerns around that you might want to flag. If they have an asserted name or nickname that might suggest some gender diversity, or if their preferred clothing or expression might vary in different settings, or suggest gender diversity. That's another flag that maybe this is something that a child is dealing with at any sort of developmental stage. I will say at the end of the day, and I go back to this, when we see young kids, especially pre-pubertal kids, this is a list of chief complaints that we've had when they come to our clinic. And as you take a look at this, I think anybody who has kids, or all of you obviously who work with kids, these can be normal things that happen in terms of young kids exploring who they are. I don't think anything in this list is inherently pathological or is raising a red flag to me that we need to really engage or in any sort of medication or any sort of sort of safety measures. I think a lot of this to me is telling me this child's engaging in age appropriate sort of exploration of who they are. And a lot of what I do when these patients sort of come into my clinic is providing reassurance to parents and education about child development and child gender identity development. These are really two really good resources I want to put out there. The first one is a paper that I was part of with two people in my clinic that talks a little bit about assessment at a young age. It's actually oriented towards primary care pediatricians, but I think it could also be helpful, to people in behavioral health. But it gives you some sample questions and areas to explore, and young children versus adolescents, and along with their parents, that can help in terms of assessment. The second one comes from a book, a Springer book, on this topic, and I think is really good, by Scott Leibowitz and Aaron Jansen, which again, this one's oriented more towards mental health providers and questions and ways to assess in mental health and things that you should be, concerned about. But I definitely highly recommend both of these resources. I think these would expand in this discussion a lot more and enrich your sort of understanding of sort of the assessment process. And generally what we see in the clinic is three sort of distinct pathways. And not to say this is where everybody falls, but the vast majority of our patients, when we're looking at young kids approaching adolescence, this is really where we sort of see kids. You have the easily affirmed kid. This is the kid who's known forever, and is easily sort of affirmed and supported by their family because it's just always been a fact. This is who Johnny is. And in some sense, we might think this is sort of the easier, case to sort of work with, but there are still, in some of those assumptions, that can still set up the child for rigidity as they approach adolescence. We need to be careful that we're not closing them into a box, because we need to understand that even young kids who show gender diverse play may not end up being transgender. So we need to keep an open book and not allow our assumptions to close our assessment or close our sort of idea of what this child may want or need in the future to best affirm them. The second group is the sort of more silent child, who has sort of a childhood internal state of tension, but maybe they're more shy or, they're more closed about it. Often these are the kids that don't want to disappoint their parents, and they can't really position themselves in a way that they can really bring this up and talk about it. And this is, I think, a bigger challenge for mental health care providers, because they may not be open with you, or they may only be open with you, but they may not want to be open with their parents or other, adults involved in their life. And how you navigate that, I think, is is really important, in terms of, really sort of feeling it out with the child, thinking about their safety. This could be a really challenging trajectory, but definitely one that's very highly represented in the patients that come to see us. And then the third party is kind of the neutral child that really has just gone through like this androgynous state of, growing up. Maybe they're the tomboy, or they tend to be a little bit more, feminine, even though they were assigned male at birth. And they never really thought about that. Everybody has been kind of okay with it. And then they hit puberty and their body starts changing. And now they start to all of a sudden enter the state of like distress on what's happening. I've never had to think about this. I've never had to deal with it. And now all of a sudden my body is doing these things. It's really feeling uncomfortable. And they come in often like pre-pubertal or in early stages of puberty and really need help exploring who they are, because they've never had those challenges that have forced them to confront that prior. I think that in each of these three, sort of trajectories or any other trajectory that you might see, puberty is really a crossroads. It's a crossroads in terms of your body beginning uncontrollable changes that force often people who are gender diverse to confront that gender diversity. And often they need more emotional and social support and mental health support around that. But it's also a crossroads in terms of intervention and affirmation, whether it be sort of slowing the process of puberty down to allow for exploration, whether it be starting to allow for more social affirmation through name and pronouns so that kids can then be, really engage in that state of, understanding who they are, or even in terms of intervention, building networks of safety that allow this child their own sort of process without a, peer and especially adult influences trying to direct them one way or another, but that they have the safety to sort of engage in this process in a way that's genuine and really true to themselves. So why is mental health care important? I think that last kind of bullet at puberty kind of maybe started to foreshadow some of this, but why is mental health care important when we think about gender affirmative care, especially in children? Well, this is what we're trying to avoid, is the sense of going underground, that sociocultural pressures lead children and teens to suppress rather than explore their genuine sense of gender identity. This is also in some sense, you might talk about like going back in the closet being sometimes an analogy more for sexual orientation, but it can be used for gender as well. And so, this is fostered by internalization and self-criticism. It's manifested by secretive thoughts, feelings, and behaviors, and it's reinforced by parental distress. So if you're telling your parent or whatever that something doesn't feel right with using a bathroom, or if your parents seeing you like as an assigned male at birth using Barbies, there may be explicit or implicit messages or microaggressions that really are telling you that your parents are uncomfortable with this, and that might steer you or direct you in a certain direction. Criticism in social settings. So this might be the assigned male at birth who goes out to the grocery store to dress. And all of a sudden people are sort of whispering, staring, might be pointing. And while it's not necessarily, explicit discrimination or, explicit sort of targeting, that can make a child feel very uncomfortable. They might not understand that situation. It might really sort of play toll on their self-esteem that we need to be aware of. And then the third thing is peer policing and bullying, which I will say, we know that like 90% of the bullying that takes place in school is actually oriented around gender, that boys are sort of sissies or, aren't masculine enough, that girls aren't fitting certain stereotypes in terms of their body, in terms of their, who they're sort of like attracted to, dating. There's a lot of pressure around this, reinforced with this peer policing, and most of it, when you actually step back and think about it, most of it is oriented around these gender stereotypes and people that don't necessarily fit. So when you put all of this together, this builds a sort of trajectory that can be very negative, very promote internalization, and really over time lead to the negative mental health disparities that we see, being depression, anxiety, high risk behaviors, and the biggest concern obviously being suicidality and self-injury. And I think the data is very clear that we are dealing with a very high risk population when it comes to suicidality. This is based on a few years ago, pre-COVID, and there have been some, obviously some changes with suicide with COVID, but pre-COVID, the general population suicide attempt rate over the lifespan was 4.6%. In trans males, it was 46%, and trans females 42%. that is a magnitude higher, right, in transgender populations than the general population. That is a huge disparity. And I think we really need to understand pathways like this to understand how we can intervene and what we can do as mental health care providers to really correct this. Because in some sense, this is, I think this is, a crisis in terms of this population. And it's not just suicide. Suicide's at the top there, about the 40%, but also there's huge disparities in depression. 57% of gender diverse people experiencing depression in their lifetime, 40% with anxiety, 53% engaging in self-harm, high rates of victimization, 61% with physical assault, 63% with sexual assault, and then very high rates of various forms of high-risk behaviors. And so I think this is really important that we need to know what we're up against in terms of why gender affirmation is so important. They did some focus groups with gender diverse youth across the country in different settings, urban and rural, and more people of color versus white, and things like that. And they asked them all, what is it that the mental health care system needs to provide you in order to really sort of feel comfortable? Or you know what? I'm actually talking about the wrong slide. We will come back to that. This is just sort of saying, where does mental health care fit? And there's a lot of different models out there around where mental health care fits, right? The gatekeepers, we see that sometimes with surgery, having to write letters. The rescuers, that like our primary care doctors are doing this work, and we need to be the ones that when something goes wrong, we come in and try to like rescue those cases and get them back on track or better understand who they are. Are we the experts that are kind of removed and just providing advice to our primary care colleagues to help direct them? Or is there some other way that we can really play? And I'm not, I will say there's not a right answer to this. I'm going to talk about, as we move forward, some of the things I recommend, but this is still very much a question in terms of where psychiatry and psychology fit into the model. There was this Joanna Olson and her group out in California did a study in 2006 that I think really put the field of psychiatry sort of on its head in terms of how we understand our role, because basically what they found was that socially transitioned transgender children who are supported in their gender identity have developmentally normative levels of depression and only minimal elevations in anxiety, suggesting that psychopathology is not inevitable within this group. I think it's studies like this that really underlie the transition from gender identity disorder to gender dysphoria, that not every person, simply by virtue of the fact that they're transgender or gender diverse, inherits psychopathology and the risk factors that we are sort of talking about, and that there's hope that through affirmation, in this case, social affirmation, but through sort of affirming people and creating networks of safety for people to explore the genuine sense of self, that we may be able to reverse this trajectory of going underground. Oh, here we go. So where do these poor outcomes come from, and what can be done? So I'm not going to get into the nitty-gritty of this because I think that a lot of you are familiar with it, but I do want to bring up these various sort of mechanisms in addition with going underground to go one step deeper into, okay, what is driving them? In this case, this is looking at sort of, systems of sort of oppression and intersectionality, and the idea that trauma and multiple sort of different spheres can sort of add up in a cumulative way that really can play toll into, people who are marginalized, including transgender youth. That, and also inform systems like family systems and community systems that then propagate, some of those sort of drivers of what pull people underground, whether that be through discriminatory laws or gender norms that we're sort of seeing, which is why we're sort of steering and pointing people out in the grocery store, negative peer relationships, bullying. There's a lot of ways that, all of this becomes reinforced, this message that being transgender and gender diverse in and of itself is a negative thing. There's also the sort of minority stress theory, right? That, people who are minorities for whatever reason, in this case, gender minorities, that they face a stigma in society, stigma manifested through prejudice, discrimination, lack of acceptance, microaggressions, and then over time that actually has a physiological response in people who live in systems of stigma, where their cortisol goes up, and that plays into physical minority stress on the body, that then actually primes your body for anxiety and depression, not just through psychological pathways, but also through the physical, stress response. And ultimately, the anxiety and depression leads to risks of suicide, substance use, high-risk behaviors, all of those sort of things. And then, I'm sure many of you are familiar with sort of Bronfenbrenner and sort of his idea of like the various sort of systems that sort of come into play, especially as we're dealing with young people. But I think this sort of developmental theory is very important when we think about gender, that it's not just the individual. We have to think about the family in which they live. We have to think about the community in which they live, the school in which we live, all these various levels of support, both in terms of like why it is they're struggling with the distress and gender dysphoria they're feeling today, but also we need to think about it in terms of where and how we intervene. That it's not just one level, it's not just the provider and the patient, but really to be effective, you really need to be thinking about the systems. So that's a lot, I know. You need to be thinking about the intersectionality, the minority stress, the systems. There's a lot of underlying mechanisms and theories, sociological theories that play into this that you need to sort of be balancing and holding in terms of the clinical encounter. This sort of talks about that a little bit more with the Bronfenbrenner. You need to be thinking about the family, the school, the peers. You need to be thinking about, is there bullying? Is there, other maybe mental health stressors at place that may also be overlying and co-occurring. Teens can present for a number of reasons that may not be just gender dysphoria. It might be that they've withdrawn socially, they're depressed, they're acting out, they're anxious, they maybe have trauma based on some of the stigma and the sort of minority stress that we sort of talked about, mood variations, self-interest behavior, underachievement in school, homelessness, bullying. I mean, the list just goes on and on. So I think we need to be thinking about gender diversity, and we need to be thinking about these sort of mechanisms in any sort of patient that really is presenting to us, because it may not be as clear as a patient coming in and saying, I don't feel comfortable with my gender identity. Sometimes it's, I'm really struggling in school. And then when you dig below the surface, you understand they're struggling, and you have to understand the mechanisms and systems involved to truly be able to effectively treat those young people. At the end of the day, family support is the number one sort of affirmation and resiliency building factor. So what can families do to be supportive when a child, especially when a child comes out? So family acceptance of adolescent gender diversity is associated with positive outcomes, self-esteem, social support, and actually overall general health. And it's also, it's protective against negative health outcomes such as depression, substance use, and suicidal ideation. This is from the Family Acceptance Project out in California. And I think, and they've done a lot of really great work. I encourage anybody to go check out, their website and their studies. But essentially what this is suggesting is that family acceptance in particular, but even larger systems of social acceptance, can actually counteract that sort of system that we've been describing of going underground, and even some of those negative sort of systems that are in place around microaggressions and minority stress and things like that. So what is acceptance, and how do we sort of bring this up with a family? I often call this gender mindfulness, that often families are really focused when they come into your clinic about the reasons that a child might be transgender. Is it something that mom or dad did when they were young? Did they spend too much time with their child? Did they spend not enough? There's all these theories that sometimes parents will come in with, but also the future. They might be worried about that their child's going to have a harder development. Their child might have a harder future, things like that. And what we want to do is reframe that process to focus them on the here and now, on how they can best support their child's gender diversity today. Acceptance, as I've talked about, is sometimes a more complicated term, and it's a process, and there's a lot of hurdles along that process. As you can see from this diagram, the hurdles reflect the grieving process, because in so many ways, and sort of captured in this quote by one patient at the bottom, when I had dreams for my daughter from the day I found out I was pregnant, these are really ingrained expectations and dreams that parents have based on gender from a young age that they're letting go of. And that is a process of grieving. It brings about anger. It brings about bargaining, denial that they're not really, my child's not really gender diverse. This is just a phase, right? We hear these things all the time. And I like this analogy a lot of this process and the stages of grieving, because it helps to conceptualize for young people exactly what it is that that their parents are going through. Why is it that dad's angry? And dad's anger may be a really important part that dad needs to work through, and that we need to help support dad through in order to get him further along his process of acceptance. That can be really helpful with kids in terms of conceptualizing a lot of this. These are some of the future fears that parents might have, right? Future fear of physical harm, future fear of harassment, rejection, things like that. Fear and, sort of a lot of those worries about things that we can't necessarily answer really drive a lot of the resistance parents have to be fully supportive, affirming, and to really increase their own understanding and ability to listen to what their child is going through. So in the end, when the parent comes in and says, what's the right thing to do for my child? I break it down into these three, sort of aspects of guidance. One, you need to focus on parent acceptance as the single most important factor in the child's adjustment to their development and future outlook on life. And second, we know that patient rejection leads youth to have shame that becomes internalized, leading the youth to go underground with secretive thoughts, feelings, and behaviors. And we've talked about the negative sort of trajectory that puts a young person on. Ultimately, research has shown that even a little less rejection or a little more acceptance has improved outcomes for self-esteem, life satisfaction, and decreased risk for depression, suicide, substance use, and HIV. So this means that parents, when a child comes out to them, or if a parent is struggling, they don't need to all of a sudden become accepting in every way overnight. That's an unreasonable expectation that sometimes is thrown out there, that I think is actually detrimental to the parents' process and their ability to sort of move forward in that process. Instead, we need to really celebrate every additional step that the parent has to listen, to hear their child, and to really sort of accept and understand what it is that their child is telling them. And that, as the evidence sort of shows us, decreases rejection. To make this a little bit more simple, my advice to parents is just to love your child and to do so focusing on the here and now. Try not to worry about the future. Try not to worry about the past. We can't change that. We don't know 5-10 years who your child's going to be, but today we know who your child is telling you that they are. And the question on us is how can we best support and love your child today? And I think often parents feel if you can reorient them towards that message, that is something they can focus on and handle, whereas all those other fears become quickly overwhelming. Now, just to check in, what time does this go to?
So we're on until 1:30.
Oh, 1:30? Great, perfect. I have one more section and then we can do questions. So we're right on time. All right. So what is gender affirmative care? So this is the question that I started with. This is what I promised that I would talk about with all of you. And so I want to pull all this together in order to answer this question. So current research suggests that rather than trying to predict or prevent who a child may become, it's better to value them for who they are now, even at a young age. This fosters secure attachment and resiliency. And we've talked about that, we talked about that a bit earlier, especially when we were talking about like the watch and wait and why that's not, the best approach and how that can be harmful. Gender affirmative care is based on the belief that all children benefit from love and support. We're not trying to do things to sort of put kids who are transgender or gender diverse in a special group or to provide them with special resources. We're really trying to level the playing field so that they feel the same levels of love and support that our cisgender children are feeling. And ultimately, the goal in the end is that all kids coming to us, regardless of how they label themselves or what treatments or things like that they might want or desire or go on, that they ultimately feel more loved and supported by the systems in which they are sort of in, as well as internally. And the goal, I sort of just said that the goal, sort of explicitly putting this out there, of gender affirmative care is not treatment. It's to listen to the child and with the help of the parents and family to build understanding. That's our role. And I think sometimes that gets lost when people say that gender affirmative care is all about putting kids on hormones or, all about sort of rushing kids in one direction or, not including the parents. That's not true. The goal, simply put, is to listen to the child as a provider, as a family, and with the help of the parents and family to build understanding that's going to put that child on a more positive trajectory towards self-acceptance and being able to safely explore and understand who they are as, their genuine sense of self. Through strong, non-judgmental partnerships with parents and families, providers create environments of safety in which complicated emotions, questions, and concerns related to gender can be appreciated and explored. So this is the exact opposite of going underground. We want to create these safe environments to really allow people to come above ground and to be who they are and explore who they are. If we suppress it, that's incredibly distressing. If we allow the exploration, that's how we're going to get to really understand who these children are. And it's not to say that on day one, a child's going to fully understand that. It may be a process of exploration, but it needs to happen in a safe environment where we're not stigmatizing or suppressing, that sort of process of exploring. And gender affirmative care is most effective in a collaborative system. And this is where I come back to the whole idea, where does mental health fit? A collaborative system with access to medical care, mental health, and social services, including support for the parents and family. Kids are not little adults. And in adults, we often talk about the informed consent model, where if the adult understands the risks of whatever they're sort of taking on, then they're able to sort of make a decision on what's right for them. But that doesn't work with young people, because young people, as we all know, are still very much in a process of understanding who they are, and in that process of challenging themselves through different experiences and in sort of groups. So we have to have a more flexible approach with young people, and we have to have larger sort of teams of support, not just thinking about what medical interventions they need, but also how to best support them emotionally, how best to support them in terms of all these systems they're involved with, and how to promote safety, but and then also how to support their families and their parents, who may be going through their own process with multiple hurdles getting in the way of really allowing them to truly understand who their children are, or to listen, genuinely to their children about what it is that they're struggling with. So what does it mean to be a gender affirmative care provider, or to sort of be, sort of ascribed to this model? Well, there's 4 premises that basically, in this Hidalgo commentary, that they suggested that gender affirmative care providers all kind of share. And so if you kind of saying that you're a gender affirmative care provider, this is what you're saying that you believe, and what you the principles that really sort of orient your practice. The first one is that transgender identities and gender diverse expressions do not constitute a mental disorder in and of themselves. That variations in gender identity and gender expression are normal parts of human diversity. Again, the same as race and ethnicity and ability and all these other aspects of the fact that humans are just different from one another. And that binary definitions of gender do not always reflect emerging gender identities. As we've seen, going from the sort of, Kohlberg's theory to the gender spectrum to the planet, our understanding of what our sense of self around gender is continually evolving. And I think that's a really great thing, as we continue to understand more about the beauty of how different humans are, how different the human experience is. But we need to understand that it's a continually evolving process, and to some degree, a little bit of a moving target in terms of the terms and concepts that we use. I even talked about how we don't use gender nonconforming anymore, and we've tried to focus more on strengths-based terms such as gender affirmation and gender diversity. So this is continually evolving, it will continue to evolve. It also says that gender identity evolves as an interplay between biology, as we talked about with sex assigned at birth, what parts you have, medical treatments you may need, development, and how you might understand yourself. It's going to be different for a younger child who may be more concrete thinking than a more abstract adolescent. Socialization, you think about Groff and Brenner's model and all the systems that are involved, and then in a large sort of scale sort of perspective on it, culture. And the culture comes into play, as we talked about with the gender planet, where really our understandings of who we are and how to define that and what labels to use comes through our interactions with other people in an imperfect science. And so all of this sort of comes together when we talk about gender identity and who we are. It's complex, what we're dealing with. That's, again, part of the reason why these sort of multidisciplinary teams are so important. And then finally, if a mental health issue does exist, it most often stems from stigma and negative experiences, as we talked about minority stress theory, intersectionality, a lot of those sort of models as being the underlying reason for psychopathology, rather than it being intrinsic to the child's gender identity. Now, I do have a caveat with that last bullet point that sometimes I just really want to explicitly throw out there, that it's not saying that a transgender child is in any way immune from having a genetic predisposition to a certain mental health disorder. So if mom and dad both have depression and they have a transgender child, yes, that transgender child will have an intrinsic, risk of depression. We know about that in terms of genetics. What we really, and I'll just emphasize that last part of the sentence, that the mental health issue is not intrinsic to the child's gender identity. And so I think it's really important to understand that, because often when people say, well, I feel a little on the border about the gender affirmative care model, I think it's often because they misunderstand that last point and how mental health sort of fits into it. And the fact, it's not, that these sort of mechanisms, social mechanisms and determinants of mental illness are just, and many people are just as important as intrinsic sort of genetics and things like that. I want to break down for you. So when we talk about gender affirmation, there are different things that we can do as providers and as a team to help along the affirmation process. These things are not, there's no sequence to these things. There's also no like prerequisite, one versus the other or anything like that. There's no necessity that anyone needs to do everything on this list that I'm about to go over. But these are different ways and different things that we can explore as providers working with young people that may be helpful at certain times in their development when it's appropriate. And I will say there are many cases where these things are not indicated. It may not be desired by the individual, even though they see themselves as transgender or gender diverse. So these first three things are sort of your emotional affirmation, and they really sort of fall under an umbrella of what a therapist or a behavioral health provider can really help out with, interacting with the child, their family, and other systems involved. The first one is emotional affirmation. This is creating that safe space that I've talked about so many times today for patients and families to explore their gender, to share concerns and emotions sort of openly with each other, and to learn how to advocate for the gender diverse person. It includes early identification of dysphoria and other mental health concerns that may come up and may serve as a barrier to sort of being able to sort of openly and genuinely explore who you are. So gender affirmation is I think one of the key things that we can do and that I talked about throughout this whole sort of talk today, that I think is really important. And it can be done at any age. And it should be done at any age. The watchful waiting, we talked about that. We don't want to delay it. If somebody comes in and saying, this is, struggling with this, we want to help them in terms of exploring it and create safe environments where it can be explored, with adults and, supports within their life. And of course, it's reversible. If in that safe environment, if somebody one day is saying, hey, I feel more masculine, and then later on says, well, I've explored it, and maybe I'm not so masculine as I initially thought, that's great. That's helping, that's one further step they've gone in terms of understanding their true self. And so it's reversible, it's flexible by nature, which I think is really important to understand. Social affirmation is that maybe taking it one step further in terms of different hairstyles, clothing, name, pronouns, restrooms. Sometimes this gets involved interacting with schools, community systems, extracurriculars, and things like that to make sure that the child essentially is affirmed within their various systems in which they're involved. And we know that, from the literature, that kids who are affirmed, kids who play on the soccer team or whatever that is, aligned with their gender identity and who they feel they are, that is very important in terms of building resiliency against some of the disparities that we see. So social affirmation, again, can happen at any age. It can be an important part of somebody's exploration process. And again, it's fully reversible. If one year somebody feels that really the girls' soccer team is the one that best fits who they are and their sort of social networks and how they want to express themselves, and then the next year they feel like maybe that was the wrong choice and whatnot, that's okay. We can change that decision as we go to best sort of affirm that young child or to, when thinking about the safety of that young child. Legal affirmation is taking it one more step further, where rather than just sort of socially changing your name or how people see you or label you in terms of gender, you're now taking it to the level of changing it officially on birth certificates, school records, other documents, things like that. It is a little bit, I will say this is a little bit more, I don't know what the best word, but a little bit more sort of progressed in terms of how official you're sort of maybe making it. But at the same time, if you can change your name to one thing, you also can change your name back. It's not set in stone, as many people sort of say. And obviously you don't want people going in and going to the court every other week to sort of change their name. So there are limits to how often, somebody may do this, and that creates sort of, a higher threshold maybe. But in all reality, if a name is chosen, or if somebody really feels that a gender identity best fits them, and then later on that evolves as they sort of continue to develop in terms of their understanding of themselves, we can continue to affirm that by making adjustments that are right for that child. This next slide is on medical affirmation. So there's really two camps when it comes to medical affirmation. There's puberty blockers, and then there's cross-sex hormone therapy. Puberty blockers, so this is GnRH. If you think back to your days in endocrinology, this is the molecule that's secreted by the brain, and it plays onto the pituitary and tells your pituitary to then secrete LH and FSH, which then goes to your ovaries or your testicles and then tells them to secrete testosterone or estrogen, whichever they make. So the big question here is, okay, so if it's GnRH, which actually supports this whole process of increasing testosterone and estrogen, how does that work to block puberty? Well, the reality and the key to understanding this is that your brain actually releases GnRH in a pulsatile manner, in a very specific pulsatile manner that acts on the pituitary. And if you modify that release in any way, then you get a negative inhibitory signal conducted through the downregulation of receptors. So yes, this essentially is an agonist therapy, but the reality is because we're giving it in sort of depot sort of formulations that make it sort of constantly present in the bloodstream, we are stopping the brain from secreting it at that pulsatile manner, and the pituitary is just constantly seeing it in the bloodstream, and so they're taking in all those receptors, and the signaling is actually going down through the downregulation of receptors. So I know it's a little bit abstract to sort of describe this, but it is sometimes seems counterintuitive that GnRHA, an agonist or an analog, is actually causing suppression. But ultimately, through this pathway of using these molecules and taking away the pulsatile release, you are shutting down production of estrogen and testosterone in a fully reversible manner. Now, I need to throw this out there because I've gotten this recently from a lot of people who said, well, if it's reversible, does that mean that there's no side effects? So reversible does not mean placebo. There are still effects to decreasing your levels of estrogen and testosterone. The actual primary effect, though, is that if you stop this, your body will go right back to producing estrogen or testosterone, which will go right back to sort of activating your systems of, producing sperm and eggs, bone mineralization, all these systems that it sort of feeds on, including secondary sex characteristics. So yes, it's reversible, but based on how long you do it, or whether you follow the guidelines that are in place, especially I usually reference the ones by the US endocrine societies, which I think are the most in-depth and most thorough in terms of looking at the available evidence. If you follow those recommendations, then for the most part, we know that things are largely going to be reversible though the effects are going to be reversible when you come off of the puberty blockers. But if you are doing it over an extended period of time, and especially beyond like 16, which tends to be the sort of upper end cutoff that a lot of people use based on the endocrine society recommendations, if you're going to 17, 18, and there's no hormone introduced into the system, then you are inherently bringing on additional risks of ongoing suppression of estrogen and testosterone. Key is everybody needs to go through puberty. This isn't Peter Pan. You can't live as a kid forever. Our bodies are going to get bigger. This doesn't affect growth in terms of vertical growth and things like that. And you need adult bones to support an adult body. And so at some point, we need to allow you to go through puberty. We need to figure out what a puberty is going to be affirming for you. And that's sort of the upper limit of how long we can use these. And we can do screening such as bone scans and things like that to assess the safety to make sure that the side effects that might be inherent in longer use are adequately controlled and adjusted. So I spent a little bit more time, I think, on puberty blockers than I normally would, but I really want people to understand this idea of what reversibility means in terms of the primary effect, but also that reversibility does not imply that there are not side effects, especially if the medications are used outside or beyond current recommendations, or in somebody who may be at risk through some vitamin D deficiency or something like that. They may be at risk. You might be doing DEXA screening earlier in those populations. I think the puberty blockers right now are facing a lot of sort of attack politically and otherwise. And so it is important to have a little bit more understanding of exactly what these are and what these sort of ideas and concepts are around how blockers are used. The other half of gender affirmative care the other half of medical affirmation is hormones. So in this case, you are giving the hormone of usually the cross-sex hormone, or now known as a gender affirmative hormone, the opposite sex than what the child was assigned at birth, in order to induce secondary sex characteristics that would have happened endogenously as somebody who produces that hormone as part of their sort of endogenous system. So for example, if you have somebody assigned female at birth and you give them testosterone, the testosterone provides negative feedback on your systems of estrogen production. So you shut down estrogen, and it also facilitates development of more masculine secondary sex characteristics, such as facial hair growth, deepening of your voice, broadening of your shoulders, changes in fat distribution, so you get less hips, more of a sort of square-shaped body, things like that. And the same thing if on the flip side, if it's somebody who was assigned male at birth and produces testosterone, if you give them estrogen plus an androgen inhibitor, you're going to induce, you're going to shut down their testosterone production, and you're going to induce feminizing effects such as breast development, softening of the skin, things like that. One question that sometimes comes up: why the androgen inhibitor? Why does that have to be combined with estrogen? The issue is that estrogen has a limit in terms of how high we can go, both in terms of keeping patients in line with normal sort of levels of cisgender peers, but also because high levels of estrogen increase your risk of clots. And so we don't want to push people at risk to high levels in order to fully suppress their testosterone. So we also have to use an androgen inhibitor, which allows us to use safer levels of estrogen in order to achieve the full feminizing effect that people might want. When we talk about cross-gender hormones or gender-affirming hormones, usually we're talking about, early adolescence. And I say early adolescence because we need to, again, be thinking developmental. If somebody presents who is assigned female years old and says, I really want testosterone, if you put them on T, they're going to be shaving probably by the time they're like 10 and a half. And that's, developmentally, they're not going to fit with their peers because none of their cis boy, classmates are going to be shaving at that age. So as pediatricians and medical providers, you got to put on your developmental hat and also think about, okay, the timing needs to fit in with normal sort of developmental timing so that the kid isn't bullied or, stand out in other ways that may increase, risk. So we say early adolescence on. And I also want to add the caveat, nothing in terms of puberty blockers or cross-gender hormones are indicated prior to the onset of puberty. We will never induce puberty in a child. We will block puberty once it starts, or maybe we will help direct it once it's sort of undergone. But up until the point where a child starts puberty, it is all those first page of social affirmation and emotional affirmation. Those are the only interventions that are sort of taken. And then finally, with cross-sex hormones or gender-affirming hormones, we say they're partially reversible. There are some things like vocal change, hair growth, hair loss sometimes later in life with testosterone, or with estrogen, breast growth. Once you get to more mature breast growth, that will not go away if you stop. There are other changes like fat redistribution that will, over time, if your body goes back to making this androgynous hormone, will go back. Sometimes that's seen as something that's, sort of might be concerning if somebody really feels that the effects they're getting are not fitting. But other times, if somebody's non-binary, you can actually use that partial reversibility that might be in line with their sort of non-binary goals in terms of how they want to express in the world. I have some patients who've just gone into testosterone, so they could actually grow an after shadow or have a little bit more facial hair development, but have no other dysphoria with any of the rest of their body. And that's perfectly fine. We could use it for something like that, as that person, develops and can better articulate their goals. I throw this slide up there just to show that the effects that you get, this is in terms of testosterone, but the effects you get from hormones are not overnight. And so there is no gender emergency where you have doctors rushing in to start the hormones because a child is sort of uncomfortable or, suicidal or because of their gender dysphoria, and we need like changes immediately. It doesn't work that way. And I think oftentimes in terms of behavioral health and mental health, it's important that patients understand and really accept the expectation that this is going to be a slow process. The important part of that on the positive side of things is that it's slow and we can change things if it doesn't feel good. So although, patients and families may give consent on day 1 to start a process, does not necessarily mean they need to continue giving consent on day 10, on, month 3, on year 2, down the road, if they start developing effects and it's like, this doesn't feel right. We can be flexible with the process because of this sort of slow progression. And we are honest with our patients throughout about what to expect, when to expect it in terms of what may be irreversible. It looks like the female one didn't come up, but essentially with estrogen, the changes you would get would be very similar, where initial effect being like 1 to 6 months and maximal change really being anywhere from 2 to 5 years out with a lot of these effects. So it definitely is a slow process. And then I do want to mention gender affirming surgeries. This is, currently an area of a lot of discussion, I think facilitated by WPATH, where they produced a draft that called for younger ages of surgery. And then their final draft kind of took that out. So it's creating a lot of debate around, okay, when is the right time for surgery? I will say most of the organizations today still recommend surgery largely to be in adult populations, with exceptions, largely for top surgery, so breast or chest reconstruction, at 16 or 17, in a situation where it really is indicated in this general agreement among the team that this would be in the best interest of that young person. But other surgeries like bottom surgeries, one of the main considerations is sterility that would come from removing your gonads, and whether somebody under the age of 18 can truly, make that decision, whether parents should be making that decision for their child, or whether that really should be one when somebody reaches the age of maturity that they should be making on their own. So this is an area of a lot of debate. I don't have a lot of answers around that. And I put this up there just to say this is a part of gender affirmation, but not necessarily always a part for our adolescents. Sometimes this falls more under young adults figuring their way through this part of the intervention. And then the last thing I'm just going to show in terms of my references, is there evidence to support gender affirmative care in children and adolescents? Well, if I was doing this talk 5-10 years ago, the answer would be no. A lot of it was anecdotal based on what people were doing in various clinics and what information was being passed along. We've had an explosion in research really over the last 5 to 10 years that I think has been very helpful. So these first 2 papers I put up here are papers related to the gender affirmative care model and defining it. The second 2 papers talk a lot about social affirmation and why that's important for the mental health of young people. These are some papers related particularly to puberty blockade and why that can be important in affirming young people, and also when and how it's sort of indicated in assessing that in young people. There are now papers, these are both relatively new, 2020 and 2019, that look at gender affirming hormones in adolescents, which is huge because prior to this, we were really struggling, to say that this is evidence-based, but now we have papers that are out that are providing some support. And I know from colleagues that are doing research, we have more papers that are going to be coming down the road. And then I just put up that last reference to Sorbata, which I think is a wonderful discussion of mental health, mental health, the role that mental health plays, because I've raised that today as a question over and over again. And so I think this is kind of continues on that discussion, but also talks about the timing of gender affirmative care and how mental health can help in that process of discerning what's best for each and every child using an individualized approach. So I highly recommend that article to anybody, sort of interested. So that brings me to the end of my talk. I do want to just look back here. If anybody has questions, they've already posted in the chat. I want to make sure to sort of address those. And if anybody has additional questions, I can also answer that. But I'm seeing one by Erin. It says, just so I'm clear, are you saying that there are no times when gender dysphoria may be a manifestation of other mental health issues? So Erin, I'm not sure if you're still on it, but I don't know if you can clarify that question. Are you saying like, could gender dysphoria, rather than being a manifestation of someone's gender diversity, be a manifestation of like depression or anxiety or something like that? Is Erin out there? All right.
Sorry, I'm sorry for the delay. A patient call just at that moment. Thank you for reading the question. And thank you for the very informative talk. So the third bullet point on the slide that you highlighted, that kind of highlighted the fact that gender identity is not, that mental health issues are not intrinsic to gender identity, and I think vice versa. I think on a previous slide, I would just, and then on a previous slide, you also mentioned that there's a significant comorbidity with, or co-occurrence with ADHD and autism. And so I'm just trying to understand better, like how to untangle the rate of co-occurring developmental disorders or manifestations along with the gender dysphoria, and how you untangle that, when providing gender affirming care.
Yeah, it is hard. It is very hard in both directions, I think, because I think, for example, autism and the co-occurrence it complicates things a lot in terms of assessing gender. And on the flip side, when you think about some mental health disorders like eating disorders, the gender manifestations of, dislike with their sort of with one's body and things like that can really complicate what's the best way to manage somebody's eating disorder and nutrition. So it can go in both directions, the complications of the co-occurring disorders. I think that, in this slide, I think the big thing I'm trying to emphasize is that the announcements behind me were sort of a little distracting. But I think what I'm really trying to emphasize here is the mental health disorder is not intrinsic to the identity, as it would have been assumed with gender identity disorder, that just by virtue of having, being transgender or gender diverse does not assume, it doesn't even mean that it's a mental health disorder. Gender dysphoria plays more on the experience and that sort of incongruence and how that can manifest. So the experience of being gender diverse, especially within our current society and culture and things like that, could definitely give rise and contribute to a mental health disorder, being gender dysphoria or complicating depression or anxiety, but that it's not intrinsic to the identity itself. I think is the thing we're trying to tease out here. And then, with the co-occurring part of that question, there is, I don't know if you've read anything, or I highly recommend anything written by Diane Earlshaft in terms of like neurodivergent sort of kids, and this question around, gender and how all of this sort of overlaps and interacts. I think her, real takeaway is that it's complex, but really to celebrate the complexity, that it's going to take longer in terms of your sort of exploration. And to some extent, it's complicated by the fact that kids often who are neurodivergent are a little bit more concrete and may not be able to project in the diverse ways that other adolescents may be able to project, what they're sort of want in terms of, their sort of gender journey. And sometimes it means if you are going down the route of medical interventions, to go a little bit slower and allow the effects to come in a little slower and to follow them more closely so that you're reflecting each part of the way on whether something's affirming or not. Because again, sort of thinking out into the future can be very, very challenging. But Diane has some great ways of sort of talking about having these conversations with people who are, like I said, neurodivergent and whatnot on the spectrum, that I would definitely recommend. And that in and of itself could be a whole lecture in and of itself. But I find personally that it's the rigidity and the black and white thinking that sometimes can make the early, the assessment of exactly what, their thinking can be, in terms of their pathway can be hard. Often, it's things like, an autistic or high functioning autistic kid sort of coming in and saying, look, I'm, I really do hang out with a lot of female friends, and instead of male friends. And so I think that I might be female, but at the same time, I really like, wearing boys' clothes, and I don't know, I masturbate. My private parts are not are not uncomfortable to me. And how do I make sense of that? Because it doesn't fit into either of those rigid boxes of boy versus female, of male versus female, boy versus girl. And it's exploring that I think is sometimes the challenge, and trying to do it in a way that really the young person on the spectrum can appreciate, introducing ideas of gender diversity, being non-binary, that different people have different goals. I think is just really, really important, and frankly just takes more time and effort in providing that therapy with somebody who really is experienced working with that population.
Thanks. And sorry, could you just spell the Earlshaft, the last name?
Oh, I can. I have somebody here with me. I'm gonna have them actually look it up because I don't want to spell her name wrong, but I'll give you that in just one moment.
Okay, and I think we had one more question in the chat.
I'll put it up in the chat so that you see Diane's name.
And then we're gonna end. Dr. Richardson was asking, do you have any recommendations for books or narratives for adolescents with gender dysphoria and or for the parents who opposed to their child's gender identity?
We just did this, and actually I'm going to ask for your help too. So Boston Children's Hospital has a list online that's very, very comprehensive, and we used to use that for a long time and give it to families, but some of the families were telling us it was a little overwhelming. So our clinic has tried to go through and really pick out what we think are kind of the best, and the ones that we're most familiar with, that we really think capture the experience. We have one sheet for young children and one sheet for sort of adolescents, and in both sheets it gives like books for the kids and resources as well as for the parents. So I can, I'll definitely send these slides. I will include those as well. But for any of you that want to, get to it earlier, our clinic has a website that we use. It's QueerRI, so QueerRI.com. And it is a really, really, we post a lot of our resources up there for our patients, but the book lists are up there as well. Yeah, that's exactly right. Somebody just put it into the chat. So I would check there. Somebody put Gender Spectrum too. They have some really good book lists there. So I think yes, I think there's a lot of really great books out there. The thing I'm going to ask you guys for help with though, is if you go through that list, we're having a little bit of trouble finding a lot of books that represent diversity in this sort of, realm. A lot of especially our adolescent books are more, people of, sort of white people experiences and sort of a stereotypic, sort of gender experience. And we're looking for experiences, I think, that more represent, what it might be for a person of color, especially maybe a Latinx family. Maybe we see a lot of Latinx families who have challenges related to religion. That sometimes might be a little bit more restrictive and isn't adequately represented in some of the books that we have. So if any of you guys, as you look at our list or as you're reading, if you have any suggestions, I would really appreciate that if you wouldn't mind sending those along. The last thing I will say too is I'm just going to put in the chat my email address, and you're more than happy if you have a book recommendation or any other questions or anything coming from today. I'm more than happy to take any emails to follow up with anyone that may stem from this. So I just added my email to the chat. Okay, so on that note, we have to end. Thank you so much, Dr. Rafferty, for sharing your expertise. There is another session. I've included the Zoom link in the chat that's open for trainees who want to come and learn more from Dr. Rafferty. And then Sylvia has put into the chat the survey for everybody to complete to get their CEUs. So thank you so much, Dr. Rafferty. We really appreciate it. And we want to make sure you have the link to the next session that's starting now. I do. Thank you. Okay, thank you. Thank you very much. I appreciated doing this. Bye, everybody.